Welcome to the ABMC Research Mini Reviews for this week. And this week is SAHMRI on Indigenous Health. But before we start, I'd like to acknowledge that we're on Kaurna land and acknowledge elders past and present, and also acknowledge any Indigenous peoples who might be involved in this webinar or logged on to this webinar. So, and thank everyone for joining us today. And we have two outstanding speakers today, Professor Alex Brown, the theme leader for Aboriginal Health Equity and professor at Adelaide University, and very clearly one of Australia's leading Indigenous health researchers. And Kim Morey, or on the screen you might see her as Alex Brown too, but Kim also from Aboriginal Health Equity and an outstanding researcher and also a board member of Callan. So very exciting to have these two speakers here today. And rather than me say anything else, I'm going to move straight on to Alex and get Alex to start the program. So thanks, Alex.
Thanks, Steve. Thanks, everyone, for joining in. I understand we're on a very tight schedule, so hopefully you can see my first slide there. Steve, is that all good?
Very good.
Okay, so thanks. What I thought I'd do is just give you a whistle-stop tour of really Wadley-Paringa Aboriginal Research Unit here at SAHMRI, sort of a little bit of where we came from, but more importantly, where do we hope to go and how can we find points of connection across the research community in South Australia. And then Kim will delve deeper into something more specific. Firstly, acknowledging we're on Kaurna country, and thanks for your acknowledgement, Steve. If I were to think about where we began, we really started in 2013 and we undertook some very foundational work, two major pieces. The first was what was called Next Steps. This was a project done in partnership with the Aboriginal Health Council of South Australia. What we did was work with people, Aboriginal people right across the state, particularly in the Aboriginal community controlled primary care sector, but in other groups as well. And we wanted to know what really kept people awake at night. What were the major worries or concerns they had that research could bend its will towards to make a difference in the long run? We not only heard the issues that mattered most to people, we also heard how we needed to behave, what the terms of engagement would be between us as researchers and the Aboriginal community. And this led to a piece of work led by Kim, which was really the Aboriginal Health Research Accord, which has become a foundational document in how we behave in a research endeavour. This work then led to us creating sort of the programs of work at Aboriginal Health here at SAHMRI. We had particular strengths in chronic disease work, a particular set of expertise around health systems research and health systems responses, a particular set of interests around stress and worry and the psychosocial determinants of health, and then some activity around reducing inequalities, which in many parts was a large area for community priorities around inequality to drive what we did. But more importantly, we invested in capacity building, we invested in really detailed community engagement, and we wanted to make sure that our program was underpinned by a very strong commitment to knowledge translation with the things that we found working in partnership with community. Our research through that next 5 or 6 years and largely has been preserved, has been focused around targeting leading contributors to inequality experienced by Indigenous Australians. We have a particular area of focus around premature mortality. This is the cardiovascular disease, diabetes, and increasingly work in the cancer space. A focus on morbidity, social emotional wellbeing, but also when James Ward was here, a very strong focus on STIs and bloodborne virus and substance use. And we really try to have a much more holistic and integrated approach to some fundamental work right through to how we translate into policy and practice the work that we do. So I focus on the burden of disease. We've done a whole range of trials, some pharmacological, some non-pharmacological, looking at models of care. We know very well how to do epidemiological surveillance, done a lot of work in evidence synthesis. Our particular area of interest is around the biological underpinnings of inequalities, and particularly what drives risk and disease in marginalised populations. And we bring to that a whole range of research techniques. We're probably strongest in the mixed methods health system space and public health surveillance and epi. Kim may touch on this a little bit later, but our new iteration of Wagli here at SAHMRI has been to focus our attention more intently on overcoming inequity. And so we have me there leading away, wearing a waistcoat and glasses, looking very sharp, and fancy pants here in SAHMRI. But the real action of what we do happens below the guy who takes all of the accolades, and that's from Aboriginal and Torres Strait Islander postdocs, Odette Pearson, Kim Morey, Carla Canuto, and Natasha Howard, who runs our implementation science platform. So what we did was change really from disease focus areas really to capability platforms or pipelines to make sure that we could apply our expertise to any specific condition. We want to be focused on what skill sets would enable us to make a difference outside of any particular disease silo. So we went pretty clearly from disease issues through to capability platforms within our firm. I'll just touch on a couple of the key studies. The first is the Aboriginal Diabetes Study, or the Prophecy Study. We had a really fancy acronym for this. We took it to the community and they said, don't be all fancy, it's the Aboriginal Diabetes Study, so that's what we call it. And this is really the first large-scale population genetic study of diabetes and diabetic complications in Aboriginal Australians. It took us 3 years to get up in terms of the community consultation. What we're really trying to understand is how do genetic variation, gene expression, and individual phenotype characterisation operate within the context in which people live, and what are the real drivers of complication development in Aboriginal people, where we see very high rates of kidney disease, blindness, peripheral arterial disease and amputation, and the macrovascular coronary disease in particular. What we learned very quickly was you can have a research project, that's fine, Alex, if it's the right thing for us as Aboriginal communities, but you need to be focusing on the drivers of inequalities. You need to be dealing with the health systems and whether or not they're caring for us the way they should. And you need to be dealing with the root cause issues in our communities, which was always framed around the psychosocial, the social, the environmental determinants of health. So we've got a research project that often offers a whole range of issues around health system interactions and research, and also individual support dealing with the social inequalities that Aboriginal families face. As you can see, we started in 2013, we're now in 2020. We now have a suite of programs around diabetes in particular, strong focus on diabetic complications, which was what the community demanded of us, but understanding that we need to focus on workforce. We've just recently received funding from the MRFF led by Odette Gibson to do some work around Aboriginal diabetic workforce development, with ongoing work around the social determinants and actually intervening or doing something about inequality. And we understand how important it is to translate the research that we do into real world benefit to Aboriginal people. We're doing things like improving access to diabetic foot care right across the sort of northern part of Australia, and supporting health systems with evaluations and other things as required. This is the Diabetes in Workforce program Odette's leading, really focused on developing a peer support network, online modules to support Aboriginal and Torres Strait Islander people who are working as health practitioners to better understand diabetes and respond. The Population Health Platform is made up of Odette, Pete as a party, who's a joint position with the Burnett, very strong focus on adolescent health. Kuti Canuto does men's health work, particularly around primary care, but increasingly in the broader context. And Adriana, who's doing work in the aged care space, which we've been dragged kicking and screaming to support as well. The Landscape project is probably the biggest piece that Odette works on, and this is really just looking at how do we track and monitor inequality as it exists in South Australia through administrative data sets. And we have very strong relationships with communities to develop this data into a way in which they can accept, understand, and act upon. And Kuti's doing a whole range of work around actually what do models of care need to be from men's perspectives and how do we deliver them. The implementation science platform, very strong, piece about doing things. I think if we were to have a t-shirt, it would be Wabi Paringa, we do things. You can't do things without implementation science, in my view. Obviously, a very large program of work around our diabetes study. But we've done some novel work around social determinants of health. We have a language reclamation and social emotional wellbeing program working with Bangla community across the Eyre Peninsula. Again, the social determinants interventions work, and increasingly trying to work on the complication story of diabetes and help build models of care that deliver necessary access to evidence-based therapies. The capacity development work led by Carla Canuto has a very national focus, particularly through an Indigenous researcher network funded through ARA and the Translation Centre here. We have statewide activity focusing on developing a cadre of Aboriginal and Torres Strait Islander people who understand translation science and can deliver it. So that's very much strongly about building from the grassroots up. And then a whole range of activities that we do internally. I think our investment in capacity building has been why we've gone as well as we have over the last few years. And finally, or second to last, we try to frame up our work that has relevance to national priorities and issues. This is the Uluru Statement from the Heart, which speaks to a couple of key issues influencing the health of Aboriginal and Torres Strait Islander people. One, Aboriginal people are sovereign in this nation. It's never been ceded, and their land is inalienable and a central part of who we are as Aboriginal and Torres Strait Islander people. We think there's a research agenda to support that program. In the middle, as mentioned in the Uluru Statement, very high rates of incarceration in Aboriginal young people, and we think there's something to be done there, very importantly. And we hope really that we can provide to the next generation the best of both worlds, both an Aboriginal understanding and knowing of the world, married with all that modern society has to offer. And finally, what we're really trying to get to as a group is really understanding from a methodological sense what drives and what's the causes and impacts of inequality and how do we measure it and hold systems to account. We want to understand what can be done about it. So it's not enough to know that inequity exists. How do we overcome that, both from an individual level to a structural level? And then what are the important biological understandings we can get from both what we understand about how inequity is built and constructed and its impacts on health, but how we overcome it. So I might leave it there, Steve.
Thanks very much, Alex. Brilliant as always. Fantastic. So I didn't say at the beginning, but if you have a question for Alex or later on for Kim, please type it into the Q&A box and I can then ask Alex that question. Maybe I'll start, Alex, and the Uluru Statement from the Heart, how important to health is that? And what can we all do to push that forward?
Yeah, so I think it is really important. I mean, there's mixed views, as you would expect from many different nations across Australia, which make up Aboriginal and Torres Strait Islander peoples. Some people are very strongly behind this movement and what it represents. Other people are a little bit less certain. Our view, my view certainly in a research context, is there's very important lessons within the Uluru Statement about how Aboriginal people and mainstream society can get along a bit better. And some of it is about giving up a little bit of power, but not to a point of Aboriginal and Torres Strait Islander people riding over the top of the rest of mainstream society. It's really about partnership and equivalence. So I think on that very simple level, there's plenty in the Uluru Statement for us to engage with. As I mentioned in one of those slides, how do we deliver the best of both worlds to the next generation is really important. How do we stop our kids ending up in prison? And then how do we use the way in which Aboriginal and Torres Strait Islander people understand the land and how important it is as a country to our health? How can we use that as an intervention point, particularly in the concept of, say, chronic disease or chronic unemployment and income inequality and other social determinants? So you can look at it from a high umbrella level, but I think you can also drill down into the specific conversations inherent within the Uluru Statement and see where there's opportunities to make a difference. That's how we've approached it.
No, that's terrific. And is there something that we the rest of the SAHMRI community, the rest of the ABMC community can do in regard to the Uluru Statement?
Well, I think there's an important symbolic gesture about the importance of acknowledging and endorsing these sorts of things. I think for some people that really makes a difference. Many politicians in Australia don't really like symbolic gestures. I think if followed up with the right practical supports, symbolism does matter, particularly in race relations in Australia. And I think we do need to get better at reconciling mainstream society, and particularly non-Indigenous Australia, with Indigenous Australians. And I think part of that is doing that. I think we need to commit to our RAP process. And I think we need to make sure that if we've got something to offer Aboriginal and Torres Strait Islander people or communities, that you come and talk with us and we can work out how best to connect you with doing something really practical.
Thanks, Alex. That's terrific. All right, we might, actually there's, is there a question there? Let me have a look. How much is the progress in genetic research in this population? How do you handle ethical issues related to genetic studies, Alex?
Yeah, so this is a really complicated question. I'll probably need another 8 minutes just to answer this. I'll try and do my best. I mean, where we began was a very open conversation with communities about whether or not this was even an acceptable research paradigm to progress. There were concerns around genetic determinism and, you know, playing out this narrative that Aboriginal people were inferior in some way, and utilising genetic science to actually just uphold these very, very racialised and problematic issues and perceptions of us. Where we got to with communities is a very strong sense that if applied for the right questions that the community had defined themselves under the right set of controls, that it was possible. And they supported us to progress this to ethics and then to NHMRC applications, which was eventually successful. So the way in which we try to manage this is to make sure that we respectfully, openly acknowledge and do justice to the gift given to us. And that's not just their genetic material. It's every story we get and every questionnaire that's filled out, we treat as a gift given to us by community for the purposes of progressing our research. So that changed the way we understood what we were doing. And it wasn't just about genetic research, it was about us as custodians and us as guardians of a process of protecting the rights and interests of Aboriginal people, including genetics. And I think that changed the dynamic of the conversation we were having. Now, we've got a whole bunch of checks and balances in place as well. But to sort of give you a short answer, it was really about renegotiating the terms of our custodianship relationship with what the gift was given to us. It's probably the shortest answer I can give.
Yeah, no, a really important question and a great answer. Thanks, Alex. Going to move on to Kim now, and it's great to have Kim on board. We're very proud of Kim here at SAHMRI and really proud that she's also been invited to join the board of Callan and providing that leadership at the hospital as well. So no further ado, Kim, go for it.
Thank you, Steve, and thank you for having me. So obviously I won't go into introducing myself. Steve's done a very good job of that, but I would like to acknowledge that we are meeting on the lands of the Kaurna people, and I'd just like to pay my respects to their ancestors, to the elders, and to the future generation of the Kaurna people, and acknowledge their ongoing spiritual relationship to this place that we live and work on. So thank you very much for having me. I'm going to touch on one part of the platform of work that Alex spoke to. He spoke about the 4 platforms, but I'll speak to the platform that I'm responsible for, which is the Health Systems and Services platform, and give you a bit of a snapshot of some of the work that we've been doing through this platform. I've been working with Alex for nearly 8 years, and I think I was the second Aboriginal staff member, apart from Alex at SAHMRI. So I've been around for a little while now. Okay, so I really wanted to touch on today, talk to you about the South Australian Aboriginal Chronic Disease Consortium, which comes under that Health System and Services platform. So the background to the establishment of the consortium, in about 2015, Wadley Paringa were commissioned from the Department of Health to do some work around developing particularly a Aboriginal heart and stroke plan. And through the diabetes study consultation, which Alex spoke to, we established quite early that there wasn't an Aboriginal diabetes strategy in South Australia. And given the prevalence and incidence of diabetes in our population, we felt that this was a problem. And so we spoke to the department, and we were commissioned to develop a diabetes strategy for the state. And we were also doing some work in cancer and supported the development of the second Aboriginal cancer plan in South Australia. And so really from this piece of work, there was, we submitted these plans to the department, and they said, well, how are you going to go, what would your recommendation be to implement the plans? And so really this was the birth of the Aboriginal Chronic Disease Consortium. At the same time, the establishment of the 4 first academic translation centres was occurring across Australia, and of course South Australia had a translation centre in that first 4. And so really the Chronic Disease Consortium became a priority of the translation centre, and is funded for the coordination of the work through Wadley Paringa, through the Aboriginal Health Equity theme. The consortium is really built, and the whole philosophy of the consortium is to bring all of the key partners from across the health system together, really to help us drive the implementation and influence the implementation of those 3 plans. And so as you can see, there's probably no surprises there in terms of who some of the key stakeholders are. And obviously some of those key stakeholders are also members of the translation centres, partners, organisations as well. The 3 plans, what we did to try and break it down into tasks that were actually going to be achievable, was we developed with all of those partner organisations and with members of the Aboriginal community our roadmap for action. And so the top part of the roadmap really addresses the priorities of the 3, where there's similarities across the 3 plans. So across plan priorities that are relevant to heart and stroke, diabetes and cancer. And so, they will, if we can address those areas, they'll have an impact across the 3 conditions. And then we've got specific priorities in heart and stroke, in diabetes and in cancer. And our governance structures kind of reflect the plan. So we have got leadership groups in heart and stroke, in diabetes and cancer, which are co-chaired by an Aboriginal health lead and a clinician lead and an expert in their field. And then we also have an Aboriginal community reference group and an executive group that oversees the governance structure of the consortium. So as you can imagine, that's a large program of work, the roadmap for action. And so what we learned through the first couple of years was we were probably trying to bite off a bit more than what we could chew. And a part of the learnings of the consortium is that, we have funding for the coordination of a small team to bring all of our partner organisations together, but we didn't actually have any funding to try and implement and test and pilot some of the priority areas identified in the roadmap for action. And so we have, had some success with getting some small grants to try and test some pilot work. But we found we were trying to, chase the money for a big program of work. So we've tried to kind of really hone in terms of where we wanted to focus. We're wanting to do some work in the cancer space. We've developed a model of care around healing centres and working with existing chemo centres, where a part of the rationale for those centres were to be able to provide services closer to home. And we know through some of the preliminary findings that hasn't had a big impact with the Aboriginal community. And so we've got a couple of sites that we're wanting to work with around that. We're around diabetes and their complications. We wanted to start to do some work around telehealth. And so we started with a telehealth focus, and then through that work, we've actually, Alex was able to attract some Commonwealth money through the federal minister, and we're now commissioning a whole body of work around foot complications in diabetes. And then there's the continuity of care work, which is really around heart and stroke. And we've developed a model of care around supporting Aboriginal patients that are coming into hospital for cardiac related conditions. And so the model's developed, and we're really wanting to try and test that down the track. So here's some of the kind of policy and other documents that I've mentioned. So our roadmap for action. The Aboriginal Cancer Healing Model is the model that's being developed. And like I said, we'd like to test that and localise that in a couple of sites across South Australia and then measure the impact of that. And then we've done some work in various areas of those priorities, but one area was around risk factor assessment and screening. And so what we know is that there's, through Medicare, there's an item that Aboriginal people can get access to a full health check through GPs and through primary care services. But what we've found through the evidence is that there's not a standard approach at times to getting this, this health check done. And so we've done some work across the sector to develop this screening and assessment tool that really looks at all the risk factors and provides some consistency around how these health checks should be undertaken. And so this tool's now been used for training purposes and picked up through some of the SA Health sites where they're providing primary care services, but they can't actually claim the Medicare item. And so that's where some of the variances in terms of the health checks come into play. And so we've done some policy work around that. We've also done some work with emergency services and developed a emergency services protocol to assist when Aboriginal people are being evacuated out of particularly remote communities, and various other policy kind of work we've also done in terms of influencing systems. None of this work is possible without our community, and so all of the 3 plans that were originally developed were developed in partnership with Aboriginal people and communities. And our community reference group are really important in terms of our ongoing work. What we found was when the plans were developed, we had community members asking what was next and how could they be involved in the implementation of the work. You know, some of those members of the community have been involved in some other plans that have been developed and really saw implementation failure and felt really frustrated by that. So without our community reference group and our community being involved in our work, we're unable to achieve the things that we need to achieve. And so Uncle Moogie and Auntie Janice are really proud that this work's been led by Aboriginal people for Aboriginal people. And that was all I really wanted to cover today. So I hope I haven't gone over time because Alex always watches me with the time. I'm a bit light to talk, but if there's any questions, I'll be happy to try and field them for you. Thank you.
Thanks, Kim. That was brilliant. And I think Alex went over time, not you. So, but again, I just want to emphasize that if people want to ask a question, please put it in the Q&A box. And again, I might start, Kim, and just ask what's perhaps been the biggest block in rolling this out? What have you found has been the biggest thing that's prevented you from rolling out these fabulous plans and implementing them?
I think one of the key learnings is that bringing all of the partners together has been a really important experience, and actually having people, you know, share priorities and getting people on the same page has been a critical piece of the work. And our evidence has informed workforce models, for example, particularly in Carlin with the rollout of the Aboriginal health practitioner program of work into cancer, renal, cardiac and into the emergency department at Carlin. But I think some of the barriers have been having the funding to be able to test and pilot some of the models, and within reasonable timeframes and within an environment that's constantly kind of reforming, I think are some of the challenges that we've experienced, and ensuring that kind of the evidence and the Aboriginal health is a priority, I think is, you know, often difficult when there's so many competing priorities. So I think that's a learning that we could take away from this experience, that if we had the money, I think we could really implement a lot of the evidence, but it's chasing, you know, it takes a lot of time, as you well know, Steve, chasing kind of grants. And, you know, we have a monitoring and evaluation framework that, you know, is an overarching framework that we're measuring the consortium against, and then individual programs, we want to be able to measure the impact to show the sustainability or the reasons why we should sustain these programs. So I think it would be about having the money to test and pilot.
All right, thanks for that. The other question I have is, you know, often people think of Aboriginal people as being living essentially remote, and yet when you look at the epidemiology, there's a lot of people living in, probably more people living urban than rural and remote. So what's been your learnings through the development of these plans and the implementation of the plans about the different challenges of urban versus rural and remote communities? Because they must be quite different challenges. One's got distance and the others have other issues.
Yes, you're absolutely right. Half of our population does live in, you know, the metropolitan area. But that doesn't mean that there's not still access issues and difficulties for people to be able to access services and care. You know, there's still issues with people trying to access transport. There's problems with, you know, access to affordable housing, food security. Those issues are still relevant often in a metro-based and urban environment. Obviously, the more remote we get, the more kind of complexities for people in terms of language and, you know, transport, you know, being away from country, being away from home, being away from your family, you know, that adds, you know, levels of complexities to people's experiences. You know, the rates of chronic conditions increase with remoteness, and that's well established. So there are different issues that are experienced by Aboriginal people depending on where you live, but, you know, Aboriginal people living in metropolitan areas still experience significant disparities and, you know, and access to services. And, you know, poverty doesn't discriminate on your postcode. And, you know, and a lot of the issues that our people are experiencing is really, you know, related to being, you know, in low SES status and battling poverty.
All right. Well, thank you, Kim. We're now just a fraction over time, but I think this has been a fabulous session. I've learned a lot, and I hope everyone else on the call has also learned a lot. And I'd just like to end by thanking both Alex and Kim for, firstly, outstanding work. And I should broaden that, actually. The outstanding work of the Aboriginal Health Equity Group downstairs is, you know, it's clearly the #1 Aboriginal and Torres Strait Islander health group in the country. I think there's no doubt about that. I can say that. I'm not sure whether Alex can, but I think looking across the country, there's no doubt in my mind how good they are and what an impact they're having. And so just like to thank the whole group, and then particularly Alex and Kim for giving up their time to talk today. Thank you very much.